Margaret was 63 years old when she sat across from her doctor and said something most people never say out loud. She had been married for 31 years. She was in good general health. She exercised 3 times a week and kept her diet reasonably clean. But 4 years after her hysterectomy, she had stopped experiencing orgasm entirely. Not that it had become more difficult, not that it had simply changed. It had vanished, and she had spent 4 full years assuming that was simply what happened to women after 60. What her doctor told her next changed the next decade of her life. He told her that was not normal aging. He told her that the loss of that response was a measurable biological signal, the result of specific physiological changes that were identifiable and many of which were directly addressable. He referred her to a pelvic floor specialist, ordered a hormonal panel, and gave her something no one had ever given her before. A complete picture of what was actually happening inside her body. I am Dr. Sophia Ramirez, and that is exactly what we are going to do today. We are going to build a complete science-based picture of what actually happens inside your body during orgasm, from the first signal in your nervous system to the hormone flood that follows, to what your brain does in those remarkable seconds, to the cardiovascular response, to what every single one of those changes means specifically and practically for your health after 50. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you have any condition affecting sexual health, hormonal balance, cardiovascular function, or pelvic function, please work with your doctor before making any changes to your routine. And if this is your first time here, if someone sent you this video or you found it on your own, subscribe right now before we go any further. Because the section I am about to reach in the next few minutes on what your brain actually does during orgasm is the piece that changes the way you understand the relationship between sexual health and cognitive aging after 50. It is the part most people have never been told. Subscribe and stay with me. Let's start at the very beginning. Before any hormone moves, before your heart rate climbs, before anything you would consciously recognize as a sexual response begins, there is a conversation happening between 2 branches of your autonomic nervous system, the part of your nervous system that operates automatically below the level of conscious thought. Your autonomic nervous system runs in 2 primary modes. The parasympathetic mode, sometimes called rest and digest, is the mode of calm, safety, and restoration. The sympathetic mode, fight or flight, is the mode of threat, urgency, and mobilization. Sexual arousal begins almost entirely in the parasympathetic system. This is why your body must feel safe to become aroused. Not emotionally safe in a vague sense, physiologically safe. When your cortisol levels are chronically elevated because of unresolved stress, poor sleep, or sustained anxiety, the parasympathetic system is suppressed. And arousal cannot properly begin because your nervous system believes at a cellular level that you are in danger. This is not a mindset problem. It is a biochemical one. Now here is where it gets extraordinary. As arousal deepens toward orgasm, something remarkable occurs in the nervous system. The sympathetic nervous system is suddenly recruited alongside the parasympathetic. Both systems, which normally operate in direct opposition to one another, are simultaneously activated at full force. That collision, that neurological tension between 2 opposing systems firing at the same time, is a core part of the mechanism that generates the intense physical sensation of climax. Think of it like 2 rivers merging at full current. The force at that confluence is greater than either river alone. That is precisely what your nervous system is doing in the seconds before and during orgasm. A study published in the Journal of Sexual Medicine examined pelvic nerve activity during orgasm and confirmed that the pelvic nerve, a primary parasympathetic pathway, and the hypogastric nerve, a sympathetic pathway, both fire simultaneously during climax in both men and women. This dual activation is not incidental. It is the mechanism. The practical meaning of this is direct. Anything that chronically elevates your sympathetic nervous system, unmanaged chronic stress, untreated anxiety, persistent sleep deprivation, certain classes of antidepressants, some blood pressure medications, directly impairs your capacity for this dual activation. The impairment is not in your desire. It is in your wiring. And when you understand that clearly, you understand why treating those upstream conditions is not a separate conversation from treating sexual health. They are the same conversation and they belong on the same appointment agenda. Subscribe right now, because the hormone cascade I am about to describe in the very next section includes a compound that has been studied in connection with natural killer cell immune activity and 2-hour sustained reductions in your primary stress hormone. You do not want to miss this part. The instant your nervous system fires that dual activation signal, your endocrine system launches one of the most coordinated, rapid release sequences in human biology. Let's go through it one hormone at a time, because each one matters. Dopamine rises first, not at orgasm itself, but throughout the entire arousal phase building toward it. Dopamine is your brain's anticipation and motivation compound. It drives goal-directed behavior and creates a sense of urgent forward momentum. During sexual arousal, the dopaminergic reward circuits in the brain, specifically the nucleus accumbens, show sustained elevated activity. This is the same system activated by music that moves you, by achieving a long-worked-for goal, by the smell of a meal you love. It creates focus, neurological urgency, and momentum toward completion. And then, at orgasm, the dopamine system delivers its full reward signal, a sharp release that creates the sensation of satisfaction and neurologically reinforces the behavior. Oxytocin floods in next, released from the hypothalamus and pituitary gland. Most people know oxytocin as the bonding hormone, but that name dramatically undersells what oxytocin actually does. Oxytocin is a neuropeptide with receptors throughout the brain and body, and its effects extend far beyond emotional connection. A study published in Biological Psychology found that oxytocin release during orgasm was associated with measurable reductions in salivary cortisol levels in both male and female participants for up to 2 hours post-orgasm. 2 full hours of biochemically lowered stress response triggered by a single physiological event. Oxytocin also raises the body's pain threshold, helps regulate blood pressure, and has documented effects on gut motility, which is why sexual activity sometimes reduces the cramping associated with menstruation and certain digestive conditions. Simultaneously with oxytocin, endorphins are released throughout the central nervous system. Endorphins are your body's internally manufactured opioid compounds. They bind to the same mu-opioid receptors that pain medications target. This is why orgasm is a legitimate pharmacological analgesic. Not a metaphor, not a distraction from pain, a direct biochemical intervention in your pain signaling system. Research published in the Journal of Neuroscience documented that endorphin release during sexual climax rivals that seen during intense aerobic exercise, and in individuals with good cardiovascular fitness, the endorphin response is even more robust. Prolactin rises sharply immediately after orgasm and is responsible for what researchers call the refractory period, that window of calm, satiation, reduced desire, and physical stillness that follows climax. Prolactin is also deeply involved in immune regulation. Elevated prolactin following orgasm has been studied in connection with natural killer cell activity, your immune system's frontline responders to abnormal and potentially dangerous cell growth. The data here is still developing, but the direction across multiple studies is consistent enough to be taken seriously by researchers in the field. And for men specifically, there is a secondary testosterone pulse that occurs within minutes of orgasm. It is not dramatic in magnitude, but it is measurable, and researchers believe it contributes to post-activity, muscle tissue recovery, mood regulation, and the hormonal environment that follows an evening of sexual activity into the next morning. What this cascade means in plain terms is this: your body did not develop this response accidentally. Dopamine, oxytocin, endorphins, prolactin, testosterone released in sequence in measured amounts for documented physiological purposes. If a pharmaceutical compound reliably produced this sequence of outcomes, sustained cortisol reduction, pain relief, immune support, pair bonding, tissue recovery, without meaningful side effects, it would be considered one of the most significant agents in preventive medicine. Your body already makes it. Now we reach the section I want you to pay the closest attention to. Because what happens inside your brain during orgasm is the finding that changes everything about how you think about the relationship between sexual health and mental health after 50. If you were asked to predict, you would probably expect that during one of the most intense physical experiences the human body can produce, the brain would be running at maximum capacity. Every region firing, maximum neural output. The research shows the opposite. Dutch neuroscientist Gert Holsteger and his team at the University of Groningen used positron emission tomography, PET scanning, to observe brain activity in real time during orgasm. The study, published in the Journal of Neuroscience, produced a finding that genuinely startled the scientific community. The lateral orbitofrontal cortex, the region of the brain responsible for self-monitoring, critical judgment, fear assessment, rational analysis, and conscious self-control, largely deactivates during orgasm in both men and women. Your brain's most critical, analytical, vigilant center goes offline at the moment of climax. Holstiger described this brain state as resembling what is produced by certain forms of sedation, not unconsciousness because the sensory cortex remains fully active, but a condition in which the part of the self that worries, judges, plans, and fears is temporarily and completely switched off. Completely sit with that. Your brain voluntarily disables its worry center, its self-criticism engine, its planning and fear monitoring system. For a brief, regular, physiologically induced window, the internal voice that runs continuously in the background of your life, evaluating, calculating, anticipating, dreading, simply goes quiet. For adults over 50 who statistically carry higher chronic levels of rumination, self-monitoring, worry and anxiety-driven mental activity than younger adults, this is not a trivial finding. Chronic overactivation of the prefrontal cortex is one of the central neural signatures of anxiety and depression. The regular, temporary, physiologically produced deactivation of that region is neurologically restorative in a way that very few other human experiences can replicate. Think of it as a mandatory reboot of an overheating system. Your prefrontal cortex runs hot when you carry chronic stress. Orgasm gives it a scheduled rest. Meanwhile, the hippocampus, your memory formation center, remains active throughout. This is why emotionally connected sexual experiences are encoded powerfully in long-term memory, sometimes more vividly than events of far greater practical importance. A study published in the Archives of Sexual Behavior followed sexually active and sexually inactive adults over the age of 50 and found that sexually active participants performed significantly better on standardized assessments of memory recall, attention, and executive function compared to their sexually inactive peers, even after controlling for age, education, and other lifestyle variables. The researchers proposed that the hormonal environment and regular neurological activity associated with sexual function serve as a form of cognitive maintenance, keeping the reward circuits active, the stress hormones cycling through their natural patterns, and the prefrontal cortex receiving its periodic, physiologically forced rest. The myth worth naming directly here is a cultural one, the persistent, damaging idea that interest in sexual health after 60 is somehow unusual or excessive or a signal that something needs to be managed. The research does not support that idea at any level. A robust and consistent body of evidence links regular sexual function in older adults to better brain health, better mood regulation, and better cognitive aging outcomes. This is not a footnote in the research. It is a primary finding. Stay with me, because the next section on your cardiovascular system contains something I specifically want you to bring to your next doctor's appointment. Let's talk about what happens to your heart and cardiovascular system during orgasm, because it is both less alarming and more beneficial than most people in this age group have been told. During the arousal phase, heart rate climbs steadily. In the 60 seconds surrounding climax, the average heart rate in a healthy adult reaches between 130 and 180 beats per minute. Blood pressure rises in parallel. Systolic pressure can temporarily increase by 40 to 100 points at peak. Breathing rate accelerates. Skin flushes as peripheral blood vessels dilate to release heat. Muscles throughout the body contract involuntarily, particularly in the pelvic floor, thighs, and abdomen. This is a full cardiovascular event. Here is the number that matters. Researchers studying the metabolic demand of sexual activity in a study published in the American Journal of Cardiology determined that the peak exertion of orgasm requires approximately 3 to 4 METs of aerobic effort. For context, that is roughly equivalent to walking briskly up 2 flights of stairs. The analogy I want you to hold is this. Your heart does not know the difference between climbing stairs and reaching orgasm. Both are moderate aerobic events. Both require healthy, flexible, responsive arteries. Both benefit from a conditioned cardiovascular system. And both improve in ease and safety when the underlying vascular health is good. A longitudinal study in the American Journal of Cardiology followed over 1,000 men over 50 and found that those who reported sexual activity twice weekly or more had a significantly lower incidence of cardiovascular disease over a 10-year follow-up period, compared to those reporting once monthly or less, even after adjusting for age, body weight, smoking, and physical activity. Now, the myth here is persistent and it causes real harm. Many older adults and some clinicians operate under the assumption that sexual activity following a cardiac event is too dangerous to resume. The American Heart Association's published position on this is unambiguous. For patients who can achieve 4 METs of exertion without symptoms, walking 4 miles per hour on level ground, sexual activity is generally considered safe. Their recommendation is that this be evaluated explicitly with your cardiologist, not assumed off limits by default. If you or someone close to you has been quietly avoiding intimacy following a cardiac event because no physician ever specifically addressed it, that silence has been costing something real. Bring it to the next appointment. Ask about your MET tolerance. Ask directly whether sexual activity has been evaluated as part of your recovery plan. Now we move into the territory that is most directly actionable for most of the people watching this. Because the physiology of orgasm does change after 50, and understanding exactly how it changes is the difference between accepting a quiet decline and actively managing a set of treatable physiological shifts. For women, the most significant change begins during perimenopause and continues after menopause. As estrogen levels decline, the tissues of the vulva, vagina, and pelvic floor undergo changes collectively called genitourinary syndrome of menopause. The vaginal walls become thinner and less elastic. Natural lubrication decreases and slows. Pelvic blood flow diminishes. The tissue surrounding the urethra becomes more sensitive, and the overall response time to arousal, the time it takes for tissue to engorge with blood and begin producing natural lubrication, lengthens measurably. The result can be that orgasm becomes harder to achieve, less intense when it occurs, or accompanied by discomfort that was not present before. Many women interpret this as a signal that this chapter of their life is simply closed. They adjust. They stop engaging with that part of themselves. And then the tissue changes accelerate because reduced sexual activity leads to further decline in pelvic vascular health, which further reduces arousal response. It is a physiological feedback loop, and it moves in whichever direction you feed it. A study published in Menopause, the Journal of the North American Menopause Society, found that women who maintained regular sexual activity, including through self-stimulation, during and after the perimenopausal transition, showed significantly better vaginal tissue health, pelvic blood flow, and arousal response compared to women who became sexually inactive during the same period. The mechanism is vascular. Blood flow maintains tissue health. Sexual arousal drives pelvic blood flow. Inactivity reduces it. The tissue responds accordingly over time. This is not a motivational message. This is vascular biology. And it has direct clinical corollaries. Local vaginal estrogen, which does not carry the same systemic risk profile as oral hormone therapy, has a strong evidence base for restoring tissue health. Vaginal moisturizers formulated for menopausal tissue, pelvic floor physical therapy, and appropriately selected lubricants have all been studied and documented. These are conversations to have with your gynecologist, not searches to conduct on your own, actual clinical options with published evidence behind them. For men, the central change after 50 involves vascular function because erection is, at its foundation, a blood flow event. Achieving and maintaining an erection requires the rapid dilation of the penile arteries and simultaneous relaxation of the smooth muscle inside the erectile tissue. This process depends on the production and availability of nitric oxide in the arterial walls. Nitric oxide is produced by healthy, flexible, unobstructed arteries. As vascular health declines with age through atherosclerosis, reduced nitric oxide synthase activity, elevated blood pressure, or metabolic syndrome, this process slows or becomes incomplete. The result is not always the total absence of erection. More commonly, it appears as a longer time to achieve erection, reduced firmness, a narrower window to act on it, and a response more easily disrupted by distraction, alcohol, fatigue, or anxiety. Men who experience this frequently assume it is a psychological problem or simply aging and do not mention it to a doctor. What is critical, and what most men over 50 have not been told clearly, is that erectile difficulty in this age group is, in the majority of cases, a cardiovascular signal first. The arteries supplying erectile tissue are narrower than coronary arteries. They show the effects of vascular disease earlier. A study published in the Journal of Sexual Medicine found that men with new onset erectile dysfunction had a significantly elevated risk of being diagnosed with a cardiovascular event within 5 years compared to men without erectile symptoms. When you see changes in that window, the right conversation with your doctor addresses your arteries, not just a prescription. The refractory period also lengthens with age in men. What was once 20 minutes at 30 may be several hours at 60. This is driven by elevated prolactin sensitivity post-orgasm and a slower return of the testosterone pulse. It is physiologically normal. It is worth understanding and worth discussing with a partner rather than silently absorbing as a source of shame. Now, before I give you the last piece of this section, I want you to understand that what I am about to tell you is the most overlooked intervention in sexual health for adults over 50. Overlooked by most clinicians, overlooked by most patients, producing measurable results faster than most people expect. And it applies equally to men and to women. The pelvic floor. The rhythmic contractions that define orgasm, occurring approximately every 0.8 seconds, are generated by the bulbocavernosus and ischiocavernosus muscles of the pelvic floor. These are the muscles that physically produce the contractions you experience during climax. After 50, without deliberate training, these muscles weaken progressively. In women, weakened pelvic floor muscles directly reduce the strength and duration of orgasmic contractions and increase the difficulty of achieving orgasm. In men, pelvic floor weakness contributes to reduced ejaculatory force, shorter orgasmic duration, and reduced erectile firmness because these muscles play a direct role in maintaining intracavernosal pressure during erection. A study published in the Journal of Sexual Medicine found that structured pelvic floor training in women over 50 produced significant measurable improvements in orgasm intensity and frequency within 12 weeks. A parallel study in men found that pelvic floor rehabilitation improved both erectile function and subjective orgasm experience in men over 55, with measurable results at 8 weeks. These muscles respond to training quickly, in weeks, not years. Share this video right now with someone you care about, a partner, a close friend, a sibling, someone who has quietly accepted that this part of their life is behind them because no one ever sat them down and explained what is actually happening in their body and what can actually be done about it. Share it before we reach the close, then come back. Because the next few minutes are the most practically important of everything we have covered. Here is what to do in the next 48 hours based on what you just learned. Today, take 5 minutes and write down every change you have noticed in your sexual response over the last 2 years. Not to share with anyone, just to have an honest clinical record. Changes in arousal speed, lubrication, erection quality, orgasm intensity, discomfort or frequency of desire. Write it down so it exists outside your head as a document you can bring somewhere. This week, begin pelvic floor training. 10 slow contractions daily, held for 5 to 8 seconds each, twice per day if possible. Men and women both. Set a phone reminder. These are the muscles whose condition directly determines the quality and intensity of orgasmic contractions, and the research shows they respond in weeks. This week also, if you have been avoiding sexual activity following a cardiac event or because of a vascular concern that was never explicitly cleared by your physician, make the call. Ask specifically about your MET tolerance. Ask whether sexual activity has been formally evaluated as part of your cardiac care plan. Do not assume restriction. Ask for a specific direct answer. At your next appointment, bring the list you wrote today. Present the changes you have observed as clinical data, not personal embarrassment. Reduced erectile function, reduced lubrication, absent orgasm, changed timing. These are diagnostic signals. Your doctor cannot work with what you do not report. You now know that orgasm is not a luxury and not an indulgence. It is a coordinated, multi-system physiological event involving your nervous system, your endocrine system, your cardiovascular system, and your brain. And the research consistently links regular access to that event with measurable improvements in stress hormones, immune function, cognitive performance, and cardiovascular health across the decades after 50. Subscribe to this channel right now, because in the next video we are going to answer the question this one raised but did not fully resolve. Which specific nutrients, lifestyle interventions and clinically studied protocols have the strongest evidence for restoring sexual response after 50? Not the supplements that make promises, the ones with randomized controlled trial data, the conversations your doctor is waiting for you to initiate. That video is coming soon, and you do not want to find it months from now when someone else sends it to you. I will see you in the next one.